All right, 12:05, folks. Let's go. It's so nice. My volume is low. That's not good. Let me get the. Oh,
I think we can hear you well.
okay, there we go. Like a rock star. I got my mic right by my mouth there. Good day, folks. Glad that you could all join us on session 4 of our WrapCap Mental Health series. I just hope everyone's having a great day, enjoying the sunshine wherever you are and whatever land you get to work and play on. I get to play and work on the land of Treaty 7. Center for Newcomers acknowledges that we are on the ancestral lands of the Blackfoot Confederacy, which includes the Blackfeet of Montana, located in the USA. These lands extend from the North Saskatchewan River in Canada down to the Yellowstone River in Montana, from the Rocky Mountains in the west, east into Saskatchewan. We are located on Treaty 7 territory of southern Alberta, which includes the Blackfoot Confederacy of Siksika, Kainai, Piikani, Tsuut'ina, Stoney Nakoda, which includes the Wesley, Chiniki, and Bearspaw, Métis Region 3, and all people who have chosen to make this place their home. So again, I sincerely hope that wherever any of you are working and playing on, that you're having a good day and enjoying yourself. All right, I see that everyone can hear me now. So here we go. Today we're gonna have some fun. Very interactive. So not quite the same recording as other mental health sessions that we have. Today, you're going to see live banter, whether you like that or not. Feel free to email me and tell me you don't. But today, we're very fortunate to have Dr. Annalee Coakley join us from the Mosaic Primary Care Network here in Calgary. It's the Refugee Clinic here in town. So today, what I've asked her is to give her perspective, not this is how it is for everybody, everywhere, all the time, but to share her own lived experiences in terms of working with newcomer populations in the healthcare system, particularly upon arrival. I am going to upload her original video, which actually explains that process of how medicals are done prior and how medicals are done afterwards. But today, I thought you guys might want to know more practical things. So on the website, we'll upload her original session, but today we're going to give you some practical things about the medical needs and its relation to mental health needs. So I'm hoping you guys get to enjoy this, and it's going to be me asking a lot of questions and going, Annalee, go. All right, so before we let Annalee introduce herself and we start our first session, again, just want to confirm two things. One, this is her opinion in terms of what she's seen in terms of individuals coming into the refugee clinic here in Calgary. And two, I want to thank Annalee so much for joining us, who is recovering from COVID. So I know she's been incredibly busy the last 2 years helping support the newcomer populations in the northeast part of Calgary. And so the fact that she herself got COVID just last week, thank you for still taking the time to work with us. All right, Annalee, how about you give yourself a brief introduction, and then I'll start asking the first question.
Sure. I'm Annalee Coakley. I'm the medical director of the Mosaic Refugee Health Clinic in Calgary, where I've been working since 2009. And the Refugee Clinic has been in existence since around in the early 2000s. And so hopefully I'll just share with you my experience, and maybe hopefully you'll have the chance to share your experience as well, because I know, you know, over the decades, probably all of us who work in the refugee world, you know, every year I think, oh, I'll get through this crisis and then I'll relax, and then there's another crisis, and then there's a surge, and then I'll relax. But the crises never end. And so I feel like it's been 10 years of crisis to crisis to crisis. And now, of course, we're in the middle of the Afghan resettlement surge, as well as the Ukrainian, you know, even though they're not coming technically as refugees, but they're fleeing their homeland because of war. So from a layman's point of view, they're refugees. And now we're in the Ukrainian temporary resettlement sort of project. So anyway, I'll share some of my perspectives, and I'm hoping you can share your own as well.
Awesome, thanks, Annalee. Guys, make sure you ask lots of questions and just jump in whenever you like. And as per usual, someone is emailing me, asking me for the link. So I'll ask the first question, and then it's all you. Annalee, you and I worked a lot together. We've over the mental health series, we've got a lot of perspectives from the at-risk newcomer youth. Georgina gave us a great example last week of the realities of unification in ethnocultural communities. You've been around for a while, so I'm being polite. Our first question: you worked when the people from Sudan were coming, when they first arrived upon Canada. What medical conditions did you see or did they experience when they first arrived? And then what mental health conditions did you see upon their arrival?
So, Carolee, I actually started working after the Sudanese arrived in Canada. And so the Refugee Clinic was actually founded in response to their unmet needs. And so what ended up happening in Calgary as the Sudanese were resettling here, they had a lot of unmet needs because they weren't attached to a primary care provider or any health provider when they first landed. And what they were noticing, or at least public health was noticing, and in particular, a public health resident who is the founder of the Refugee Clinic, when he was working in the emergency department, he noticed there was a lot of Sudanese people coming into the emergency department with various conditions, often at at late stages, that could have been managed in the community much sooner and prevented, the need for acute care. And so what this public health resident did is he approached CCIS, which is the resettlement organization in Calgary, and worked with them to go, he himself would go into the resettlement center, greet the new arrivals, and would do just a basic sort of medical history, order, do a physical exam, order some basic screening tests, and address their acute needs, screen for chronic disease, then manage those chronic disease conditions. And so at least got them stabilized when they first arrived in Canada. And then over the years, the Refugee Clinic has grown to what it is today, which is now it's, a large interdisciplinary health team that follows refugees for their first 2 years in Canada. And then we do a warm handover, or we connect them at the end of their 2 years when they graduate from our program. We connect them to their permanent medical home. But with the Sudanese in particular, I feel like that's the community where we failed them as a society. So, even though our founder tried to address some of those acute and chronic conditions, it was a very small operation, and it was only very episodic. So the resident would only see the newcomer for the first few weeks after their arrival, and then they were expected to find their own sort of family doctor and have their healthcare needs met. And we know that many were not ever attached to a permanent sort of medical home or a consistent primary care provider. And we know that many of their health issues and certainly mental health issues were neglected. One of our former psychiatrists at the Mosaic Refugee Health Clinic is actually the medical director of our penitentiary system. And we know that unfortunately many of our Sudanese arrivals from 20 years ago, they're overrepresented in the penitentiary system. And this often is related to addictions issues. And that's always related to unresolved, untreated trauma. And so that community, we failed utterly. And then over the years, our program at the Refugee Health Clinic has gone on to create sort of a better mechanisms for addressing both health concerns and getting them stabilized over 2 years, and also the mental health concerns. So we're trying to address mental health issues, and so I know that we'll talk about it when we talk about some of the subsequent groups.
Thank you, Annalee, for your honesty. I know that many of the at-risk youth from Sudanese backgrounds that ended up in the Real Me program, which for any of you who are not familiar, is a gang intervention program that's run out of the Center for Newcomers. I know a lot of those young people would say one of the reasons what led them to their criminality was poor settlement supports in the first place. So that's what, so thank you for being honest in terms of where the assessments worked and really did not work.
Yeah,
So
they
then what,
did.
yeah.
Like Carolee, like they weren't assessed. Like nobody sort of addressed mental health of the Sudanese newcomers, absolutely nobody. And I think you've seen this play out on our streets, right? Like in Calgary last month, there was a gentleman, Sudanese origin, came 20 years ago or so, and he had severe mental health issues that again were completely neglected. And he ended up being shot by our very own police. So I just think, you know, and I think we see this play out again and again and again. And it, I mean, there's multiple factors here. I mean, you know, at play. But one of the factors is that people's mental health needs are unmet.
Thank you for that. So then hopefully what was done when the Syrian response occurred then? What was the medical conditions that you saw coming through the clinic door and what were the mental health issues there?
Yeah, so with the Syrian surge, if people remember, there was a huge number of Syrian refugees who were resettled very quickly over a short period of time. In Calgary, they ended up staying both at the Margaret Chisholm Resettlement Center and at a resettlement hotel on McLeod Trail. It was in the middle of winter at the height of flu season, and people were sick. So they were living in these congregate living situations, and we had outbreaks of flu and people were incredibly sick. I think they were so run down from, you know, their previous years living in very difficult situations, being sort of malnourished, having had neglected chronic medical conditions. So their diabetes wasn't sort of identified or managed. And so when they contracted influenza in Calgary, they became very, very sick, and many people had complications of influenza. So meaning like a lot of people ended up with abscesses in their lungs. People had difficulty breathing and needed to be admitted to hospital, etc. So it was an incredibly difficult time during that initial surge because of that. And people were, and luckily AHS Public Health came in and helped us provide influenza vaccine for everybody, which helped settle that outbreak, but it did go on for quite some time. And so one of the contributing factors was the fact that people for years had not had their medical needs addressed. And so generally the Syrian population is not very different from the Canadian population. So a lot of people suffered from, you know, diabetes and hypertension and heart disease. And none of those conditions had been managed overseas. You know, they were coming from places like Jordan and Turkey and Lebanon, where they had very limited access to healthcare. And so a lot of their chronic conditions were not under control. And so because of that, they often had complications of those chronic conditions. So, you know, heart disease, kidney disease, problems with peripheral neuropathy, which is problems with the nerves in their legs, problems with their sight, etc. And so in terms of their health, they sort of had bread and butter conditions, but because they'd never been managed, they were much further along in the disease trajectory than we would see here in Canada. Also, a lot of children and adults had developmental disabilities. And those developmental disabilities had never been diagnosed or managed. And then one of the biggest issues we have with adults coming as refugees with developmental disabilities is to be able to access, at least in Alberta, to be able to access the supports for people with developmental disabilities. You need to have an IQ test. You need to have this psycho-ed assessment, which costs around between $1,400 and $1,800. And it's not covered by our publicly funded system, and it's not covered by IFH. And so it's very hard in Alberta for adults to access the supports that they need if they have a developmental disability. And so that put incredible stress on our patients. And of course, stress just contributes to mental health concerns. And so with the Syrians, we saw a lot of PTSD, you know, and that, you know, naturally, like after suffering through sort of war, the way that the Syrians experienced the war, many of them had PTSD. So that would, you know, come in the form of severe nightmares, flashbacks, feeling anxious all the time, not being able to sleep, always feeling like feeling very fearful, and suddenly feeling fearful for no reason at all. If they're out at the Walmart sort of buying groceries, they might see something or hear something or smell something that reminds them of their traumatic experiences, and then they become very fearful and even have a panic attack. And I can tell you, in my personal life, I sort of sponsor a refugee family, and I remember taking them to Canada Day celebrations that July 1st after they arrived. And in Canada, we use military planes to fly over events. And my whole family, like, it was like a complete doctor fail on my part, because my family was screaming and crying. And I was like, oh my, like I had no, you know, I hadn't even thought about this. And anyway, I triggered a lot of their flashbacks and PTSD by taking them to the Canada Day celebrations. And then I was like, oh my goodness, what about the fireworks? You know, and so at least if they were prepared for the fireworks, they seemed to do okay. But a lot of our families were suffering from PTSD, who came from Syria. And then, you know, and then of course, depression and anxiety. I mean, many people lost many family members. They had, you know, a lot of grief, leaving, you know, losing their home, losing close family members, etc.
Thank you again, as always, and using that real life experience went, oh, don't do that. So I never would have thought about the military planes. I would have thought about the fireworks, but not the planes. So that's a great example of how the link between health and mental health can occur. So with the Syrian experience, then you had very interesting stories about when the Yazidis arrived to Canada and their unique medical things that you noticed, as well as mental health aspects of things. Can you go on that, expand upon that, please?
Sure. So with the Yazidi, so the Yazidi are, you know, the Yazidi resettled in Calgary, a few hundred people, mostly women and children who were kidnapped by ISIS and tortured over a number of years. Many of them have witnessed the men in their family being killed, or at least being kidnapped and disappeared. Families decimated, children missing. So a highly traumatized group of people. And what we witnessed when they first arrived, because of the way they were resettled in Canada, where it was quite soon after their trauma. So they were, you know, maybe released from ISIS, and then often within a few months, they were brought to Canada for resettlement in Calgary. There was only one pre-existing Yazidi family in Calgary. Almost nobody, very few people in Calgary speak their language, which is Kurmanji. And what I noticed when I first met, the first family that I met, which was, I believe it was either in February or March in 2017. And they came in, it was a mother and 4 children, and the 4 children were cowering behind the mother. The grandmother was also there, and a sister with severe developmental disabilities. So the children were cowering behind the mother. The mom and the grandmom were crying and screaming and speaking in Kurmanji, and I couldn't get an interpreter, and I didn't understand a word that they were saying, but we just sort of sat down and I just let them talk. And they were clearly trying to describe their experience and everything they had gone through and their community had gone through. And I knew in that moment that this was going to be different, like unlike anything I had seen before. And indeed, day after day, we received new families, and these families have suffered terrible losses. Always, they were missing somebody in their family, whether it was the husband or a child. And so they were riddled with worry about their missing children, missing husband. And then they had severe PTSD. And so the most severe form of PTSD, it would manifest as this condition called psychogenic non-epileptic seizures. And so initially, I was called by CCIS about one of the new arrivals over at Margaret Chisholm who would collapse and have a seizure. And this would go on for, an hour, 2 hours, and they'd have to call ambulance. She would go to hospital, they would stabilize her, she'd get better, she'd come home. So with psychogenic non-epileptic seizures, it's a condition where people dissociate. So it's not necessarily passing out, but it's dissociation where they're no longer sort of conscious. So they often fall to the ground suddenly without any warning. They may or may not have movement. I know with a lot of the Yazidi and subsequently in some of our other refugees that we've seen this in, they're often recreating their torture and trauma. And so in the case of sexual violence, it's very, very disturbing to watch, like very distressing. The patient themselves has no control over it, like it's psychogenic, but it's physiological and the patient has no control. So they simply fall to the ground. It can happen at any time. Sometimes it's very hard to identify triggers. And then they might be, with one of our patients who was affected, they're recreating the rape and fighting off their attackers, and it can go on for quite some time, and it's very hard not to intervene. But the treatment is actually not to intervene, just let it take its course, make sure the person is safe while they're completely dissociated, and then, take them once they regain their awareness, then you can take them to a place of comfort and safety, such as their home. But this we saw in huge numbers amongst the Yazidi women. And so that was completely new to us. Like, I had not seen this condition in the past, and I feel like I've become very familiar with this condition since. And it's incredibly difficult to manage. Like, it's incredibly difficult to resolve. With a lot of our women, especially, we had one woman who was in hospital almost every second day with this condition. And one of the drivers of her condition was the fact that she was missing her sister. So her whole family was killed. 3 sisters survived. 2 had come to Canada, but the one sister was released later. And so she desperately wanted the family to be reunited. And once the family was reunited, that was the most effective treatment we had. Then the frequency of those seizures had decreased significantly. And so I would say with the Yazidi, that was the most significant mental health issue that people suffered with. And you can imagine how that's disruptive to people's lives. Like, people cannot work, they cannot go to school. It's very distressing for school teachers, because this happened in some of our children as well as the adults. And so for teachers to witness this in the school, having to call EMS every day, every 2 days for a child, it's very stressful for the teachers. It's very stressful for the other children, especially if they're refugees. This is, again, often triggering for other refugees. And oftentimes, if there's another child in the class who suffers the same condition, it often triggers the other child to then have an attack of these psychogenic non-epileptic seizures as well. And then the teacher is faced with having 2 children who are completely dissociated and unresponsive on the ground. And so it's required a lot of work. And in Calgary, it's required a team effort. When it's children in school, it's required like special support workers being with the child in the school. So if they have one of these dissociative attacks, there's somebody there who can take care of them without having to call EMS and disrupt their entire school day. So yeah, so maybe I'll stop there because I could go on and on. Okay.
Thank you for sharing that, Annalee. I do remember in the Real Me program, we would have youth where the fire alarm would trigger them, the young Yazidi children. And so working with schools, how important that is for us in this project to get just how important Swiss plays a role. So then with learning from the Yazidis, the Afghan response is here and it's still happening. What are you seeing and what are the mental health needs?
So in terms with the Afghans, they're people who are quite affluent. They were very affluent in Afghanistan. They were educated. One person in their family often speaks English, which is a considerable advantage to the Afghan community. In terms of their health, again, it's a lot of bread and butter, like the diabetes, hypertension, a lot of pregnant women. So a ton of pregnancies where they've not received any prenatal care. I would say the condition that's a bit unusual, the health condition that's a bit unusual that people ought to be aware of in case they're dealing with newly arrived Afghans, is we have had 3 cases of typhoid. And so typhoid fever, for those who don't know, is, that's a bacteria that infects the blood. So you get it from unwittingly ingesting feces that's contaminated with either Salmonella typhi or Salmonella paratyphi. So it's and right now Pakistan has significant outbreaks of multi-drug resistant typhoid. And so you will eat food contaminated with this, and then it'll enter your bloodstream and you'll become septic. So you will end up with fever. And so usually it's a fever that you can't explain why they have fever. So it's a fever NYD. And they usually get a very blank look on their face. So they have a very distinct look on their face. They just look really out of it. And then over time, their blood pressure will fall, heart rate will increase, and they'll just seem very unwell. And so if you're seeing anybody with fever and you can't explain it, you know, it's not like fever and cough, oh, they have like a viral infection. It's fever and you don't know what the source is. Or if it's an Afghan who's coming from Pakistan, then always think typhoid and take them to hospital to get their blood cultures done to check for salmonella typhi or paratyphi. Because the treatment is a very particular treatment because it's very it's resistant to so many drugs, so they need IV ertapenem. So that would be the only unusual condition among the Afghans, and that's specific to the Afghans coming from Pakistan. In terms of mental health, so it's a lot, again, like it's a lot of trauma related mental health issues. So it could be PTSD, it could be depression or anxiety. Again, like what I would like to say is that a lot of these mental health issues, you know, we can't help the trauma that's happened in the past. We can't help sort of the situation, the reasons why they were forced to flee, that we don't have power over. But we do have power over what their life is like in Canada. And so what is driving a lot of people's anxieties, worries, inability to sleep? One is family separation. And so in all of these quick, chaotic refugee resettlement initiatives, because of the chaos, a lot of families have been decimated and separated. So they leave children behind, a spouse behind, a parent behind, and it causes people considerable distress. You know, with the Syrians, with the Yazidi, with the Afghans, you know, they often come and they can't sleep, and it's because they're worried about the child they left behind, and they're worried about their safety in Afghanistan, and they want to see them again, and or they left a wife behind, or a child's mother has been left behind because the parents are divorced, but the man is the main applicant and didn't put the mom on the list, and so they have these complicated family situations, but ultimately families have been separated and it causes distress, and there's no expedited way for the families to be reunited. And so I think when your newly arrived refugees, whether they're Yazidi or Afghan or anything else, with them having family separation as a driver of their worries and stress, and they don't have a path forward to be reunited with them, it causes helplessness and hopelessness and distress. So I would say that's a huge driver of mental health. And the other one is agency. So again, an agency is tied up to in that family reunification piece, because people don't feel like they're empowered to bring their relative to be with them. And so the other thing that we do in the resettlement process is we tell people where they need to resettle. And I understand why IRCC wants people to resettle in, you know, rural parts of Canada, etc. But a lot of the Afghans in particular, they don't have connections to that rural part of Canada, and they often have connections elsewhere in Canada, and they want to be where their natural supports are, which is normal. You know, that's normal. And we know that natural supports are key to successful settlement in the long run. But unfortunately, like I've had with the Afghans, people on the ground crying, not able to eat, not able to sleep, very distressed about the fact that they've been told they have to go to Red Deer, for example. No offense to Red Deer, but they have they have family or friends in Ottawa, and they're desperate to go to Ottawa, and they're told that they can't go to Ottawa. And the issue with that is that refugees have had their agency taken away. That's why they're a refugee. They've had their choices taken away. They've had to flee their home country, and then they've come to Canada, and they're grateful for the safety. But then we as the Canadian government are saying, we're bringing you here, but we're going to tell you where you need to live. And taking away their choice, taking away agency, it causes them moral injury. So they feel like they're being treated unfairly. And then we cause additional stress, right? And so I think we have to be very careful when we resettle refugees. We need to take a holistic approach to their mental health. Like mental health, I feel like the government thinks people who've suffered trauma, we bring them to Canada, we're just going to give them a little pill, we're going to talk to them a little bit, and then they're all going to be better. But that's not mental health. Mental health starts with, a sense of agency, families being together, being around natural support networks. We have, stable finances, access to affordable housing, food security. Like that's where it starts. And so if you take out that any piece of that foundation, you're setting them up for mental health problems moving forward, and potentially failure in the settlement process. Sorry, I know I'm ranting, Carolee. I'm sorry.
You're not ranting. You answered the question after that. You're not ranting. You're just saying what I think many of us have already said out loud many times, or in our head many times. So we don't have to ask the last question anymore. What's your concern about the Ukraine resettlement then?
Well, I mean, as we talked about, the Ukrainians are coming as temporary visitors with a work visa. And with that work visa in certain provinces, they have access, they'll be getting like a temporary provincial health number, so access to healthcare. But that doesn't mean, like, if they have access to healthcare, it doesn't really mean they have access to health. Like they have the health number, but I don't know how they're going to access mental health services. Like in terms of their health, they're going to have some basic health needs, but I don't think that's going to be their biggest concern. I think it's going to be the trauma of the war, of seeing it all the time on TV, of having their husbands still or male sons or who are in Ukraine fighting and unable to leave, like the worries about their safety, worries about their future. Like it's going to be the mental health piece that's going to be the biggest part of like one of their biggest needs, I would say. And I would say in Canada in general and in Alberta, we do not have a working mental health system. Like it is very hard to access appropriate mental health resources. And I don't know if they're going to have adequate support in terms of those foundational things. So we know family separation is going to be an issue. Are they going to struggle financially? Like, is everybody being brought to Canada? Are they going to be able to find adequate jobs that where they're able to support themselves? I don't know if if that's going to happen. If so, are they able to support Alberta? Are they able to apply for Alberta Works? And even if they are, like, frankly, Alberta Works is, as we all know, it's not really enough to support people, especially given today's inflation. Are they going to have access to affordable housing? Judging from like what I've seen with the Afghans, affordable housing is a rare commodity. And food security, given the high price of food nowadays, and access to transportation, like I feel like we're going to fail them at that first rung, especially as temporary visitors. And they don't have, they might have a lot of sort of community supports, because I know there's a ton of, there's a huge Ukrainian population in Canada, but I don't know if it's going to be enough to support them in the way that they're going to need support. And I know for most of our refugees, access to mental health continues to be a problem. And I mean, it's not even just refugees. I mean, my Canadian-born patients too have a hard time accessing mental health services. Especially culturally appropriate in first language. Like those types of supports are few and far between. So I would say my concern is that we've not really adequately addressed mental health issues in our government-sponsored refugees, or privately sponsored refugees thus far. And so I think if we're bringing people over with even more limited access to resources, because they're because of their status as temporary visitors, I don't know how we're going to be able to address their mental health concerns.
Thank you, Annalee. And you answered the question in your previous answer. So if you're okay with that, I'm going to give you the final word in terms of what should this group take away. But are you open for taking questions now?
Sure.
Okay. One of the questions arose when you were talking about the Yazidis and the Yazidi youth in classrooms. And the question was, do you think schools have been supportive with their needs?
So I think the schools have been very supportive. I don't think the schools are adequately resourced though. Like I don't think for both our adult English language learners and our children who suffer with mental health issues, especially the psychogenic non-epileptic seizures, like we did have to access a very special pool of funding, which is very limited, to get adequate supports, like to pay for that support worker, that one-on-one support worker. So the schools, like just the concern from the teachers, the principal, etc., like they have been fully supportive and on board and wanting to do the right thing and very scared for the health of the children. And so they've been on board, but I don't feel like they get adequate resources to be able to address those issues, because some of those children are high needs, and there's very little that we can do to support the schools in helping keep that student in school and managing the manifestations of their trauma, like namely the psychogenic non-epileptic seizures. So yeah, so I think more needs to be done, and I think the government also needs to take a longer view of settlement, because a lot of the youth who come, like trauma doesn't happen day one. Oh, we address it, we see it, we address it, and we're done. It's like a lifetime, it's a lifetime condition. And so, and especially with the children, when they go through puberty, when they enter into high school, when they're exerting their independence, when they're finding themselves in a bit of conflict with their parents, because the children often have their foot in both worlds and are trying to navigate sort of their traditional cultural values and and then sort of some of the new values that they're adopting. It's very tricky for children. And if children have suffered from, sexual abuse or witnessed sexual abuse in the past, when they go through puberty, there's the risk that mental health problems will manifest then, years after they've been brought to Canada. And so it takes a village, as we say, like, so everybody needs to be aware of what can potentially be triggered, and what behaviors to look for, especially the school, because the school is the first line. Like that's your first, those are the people who often recognize problems first, is the teachers. And so they need to be aware, this, maybe this 15 or 16-year-old, oh, they came to Canada 10 years ago as a Yazidi refugee. What could possibly be happening internally with them? And then look for different behaviors, anyway. So I just think it takes the entire community, and we need to look at the long term. One of the other things that I noticed with the Yazidi, for example, is now some of the youth, people who came as youth, are now wanting to get married, but they want to marry, they need to marry within their own culture. That's culturally prescribed. So there's nobody for them to marry in Calgary, and probably very few matches in all of Canada. And so they look to the community abroad. So they're looking at Yazidi in Syria and Iraq, etc. They sort of get married virtually, and then they want to bring their spouse to Canada, but Canada doesn't allow that. Like, they're being denied that. So I just feel, and then of course that causes tremendous distress within the young man or woman here in Canada. And why should, so I feel like we have this very narrow view of people's mental health, and we don't look at long-term settlement needs. Like, if you're only going to bring 300 people, and if they're a very sort of like they need to marry within their own community, who are they going to marry in the future? Like I just feel like we need to take a longer view. So anyway, okay.
Perfect. Another question they're asking, do you see any progress in increased access to diagnostic assessments? I often hear the same issues from instructors noticing behaviors that might be issues that need to be diagnosed, but these instructors do not know who to refer these newcomers to. So just wondering if you've seen any progress on access to diagnostic tools.
Oh, like mental health diagnostic tools? Is that the question? Or
access, like any increased progress to accessing diagnostic assessments?
No. No, like I feel like access is a huge issue. Like, I'm very fortunate at the Refugee Clinic, and that the family doctors are very sort of comfortable with mental health issues. We have a psychiatrist with us. We've got 2 psychologists. I know, and we can always refer to the Center for Refugee Resilience. I can refer to Immigrant Services Calgary to their mental health program if that's appropriate. But in terms of the mainstream health system, like if it's AHS mental health, access mental health, I find it's very hard for our patients to access mental health. Like, it's incredibly barriered. And so I would say I've not noticed any improvement in access to diagnostic assessments for newcomers or anyone else.
Thank you, as always, for your honesty. I'm going to move down to a couple of conversations.
Like, I feel
no, because it's got to be honest. And so at the end, like will excite our partners here, but you're being honest, and that's what people want, is the honesty aspect of it. And yes, for those of you who missed part of the earlier conversation, recording will be sent out. And also, Dr. Coakley's original presentation will be put on the Center for Newcomers website, because she was basically talking about, this is what happens when you come to Canada. So what a medical exam looks like, those type of logistical aspects of things. But I thought people would want to know her perspectives on this today. The Yazidi population, someone put down, is 1,800 in Canada, the lowest on the list. I know that a lot of Yazidis went to Winnipeg. Is that accurate?
Yeah. So that's the resettled Yazidi population, but and it's growing, because there's a few, like I've had more Yazidi come over the past few months. And then there have been some happy stories of family reunification, thank goodness. But there is a pre-existing Yazidi community in Toronto, London, Winnipeg. Calgary was somehow, I think we were chosen just because there's like CCIS and the clinic work side by side, and they thought, like, oh, they'll need mental health services, so I thought we could provide that. But again, I feel like the government takes a very narrow view of mental health, where it's like much broader. And so bringing them to a city where there was no pre-existing Yazidi, and bringing them without any leaders, like I think they should have brought not just people who suffered the worst of the trauma, but they should have also brought some of the healthy components of the Yazidi community. And they need, just to provide that support to those who have suffered. Because again, the other consideration is structural violence. So these women who were severely traumatized, they grew up in rural communities, never went to school, many didn't learn to read and write in their first language, let alone English. Some couldn't recognize numbers when they came, so very hard to navigate our society without recognizing numbers. And so their whole life plan was, oh, they grow up, they get married, they have the babies, they take care of the household, the children, etc. And now we're bringing them to Canada, this highly traumatized group of women who, from a cultural point of view, the expectation was never they would work. And now we're saying, you know what, you got to work now. You got to work. Like, I mean, it's a form of structural violence. We're trying to fit like the round peg into the square hole. Like, it's wrong. It's wrong of us to bring people without looking at the long-term consequences and how can we set them up for success. And for some people, like it's not going to be like a year of federal support and then they got to fit into our society. Like it's not fair. It's not fair to them. And it causes considerable distress in a lot of these women, and it's completely understandable.
Thank you, Annalee. If anyone knows Annalee, you know she can go off on that topic for a really, really long time. And I'm acknowledging the aspects. You can't fix a problem if we don't acknowledge it, which is really important. So thank you for saying that, and for sharing your great points. Looking forward to hearing some of your suggestions for change. So that's a good way to segment and close, and then talk about how the project, what can we do in terms of helping support that long-term journey of mental health?
Well, honestly, at the highest level, when the government when they embark on these special programs to resettle refugees or specific groups of refugees, especially when it's a chaotic resettlement process, like with the Afghans, like with the Yazidi, they need to take like a holistic long-term approach. Like their logic model is very narrow in scope. Like their logic model for resettlement success looks at English language proficiency or acquisition, and it looks at employment, and it never looks at health. And it doesn't it doesn't look at the patient and their family or the person and their family over time, like over the long term. And I feel like there's a ton of gaps that they're not addressing. So I would feel like the first step is at the policy level. So I would say they need to look at family reunification, because inevitably with these chaotic resettlement projects, family are left behind, and that's the biggest source of stress. They have to look at natural supports and resettling people in parts of Canada where they have natural supports. And so if the problem for the federal government is affordable housing, like I think we need to look at affordable housing. Like I don't know exactly what the solution is, but it might not be sending them to Red Deer, you know, because I feel like we're just delaying the inevitable. Like they're going to go to Red Deer because they feel like they're being forced into Red Deer. They're going to spend a year there, and then they're going to move across the country to Ottawa, where they have, you know, where they have cousins or whatnot. So I feel like we're just delaying the inevitable. And we have to look at each group very specifically, like what are the needs gonna be over time, and we have to put in the appropriate resources to support people over time, and we have to ensure that the refugees have agency, that they're decision makers in their resettlement journey, and we have to again, like engage with education, and we have to engage with health, and in particular with mental health, and create supports for the newcomers over time. But I feel like we invest very heavily in the first you know, like first month, 2 months, 3 months, maybe even the first year. And then we're like, you know, the federal government washes their hands of it. But it doesn't stop there.
And this might be a good time to say Annalee, what she offered in terms of how to make these changes. I don't know if I'm allowed to say this, but Annalee offered to, part of WrapCap is bringing resources together that sometimes people won't have access to. And she's offered to do training for a lot of rural areas, for a lot of professionals in those areas, for schools if you require that. And I went, really, you have time to do that? But she says that she sees the importance of providing that long-term support. So if that is something you're interested in, please feel free to email me. I'll be the conduit and do those aspects of things. Is that accurate?
Yeah. And I would just add too, like, so I am very interested. Like, I feel like a lot of the mental health supports that we do offer people, it's not a one size fits all. Like if we're looking at just like mental health supports, you know, sometimes CBT isn't right for everybody, or talk therapy isn't right for everybody. Sometimes it has to be a group. Sometimes you kind of have to Trojan horse the mental health into like a different activity. And so like one of our former residents who's coming back, she's just off on maternity, but she's a psychiatrist, and I'm going to work with her to sort of renew our whole program at the Refugee Clinic, and maybe even we can expand it to Calgary. You know how Montreal has this great sort of intercultural mental health institute, and I think we need to do the same here and across Canada to be able to better address the mental health needs of our newcomers, especially our refugees, because people are refugees for usually a very traumatic reason. And so we just don't have anything in place that's culturally appropriate for everyone, even linguistically appropriate for everybody. And we just don't have enough, like there's just not enough resources in the right place, which I think would be the school for our youth. and recreation centers. Like it's just not, like, honestly, I feel like nothing's working very well. Like there's little bits of hope, right? Like with the Real Me program, etc. But there's not something that our youth or other newcomers and refugees can easily tap into. And so I want to change that eventually. I just haven't gotten around to it.
You're a little busy. You're being thanked for your commitment to the refugee population. How do you do what you do without suffering by vicarious trauma yourself?
Oh dear. So honestly, like I don't have any good answer for that. Like I'm often not well. So vicarious trauma is real. Like it's real for all of you. And I know that you're supposed to, like, it helps me to have colleagues that I can debrief with and talk to, and they're very supportive. I try to remember, try to sort of savor the successes. Like sometimes there's some great successes. And so focus on that. And I think by trying to engage in changing the situation, I find that is helpful because you feel less hopeless. But I mean, honestly, don't get me wrong. Like I often have, like I go through periods of little breakdowns, and then I then I recoup my energies and start again. So I don't think I have any great answers for that.
But it's an honest answer, so thank you. Earlier, you mentioned about the Sudanese population that we have failed to acknowledge their mental health. Is there any more information about their history on mental health that we can access?
Oh, you know what? I'm sure there are studies. I'll let me see, Carolee, if I can find those, because I know our psychiatrist who was at the clinic, he was very involved with the Sudanese and also newcomers from Chad. They all face very similar types of trauma and being child soldiers, etc. So let me see what I can find.
Thank you, and I'll get that out to people who have asked. And I think one final question, would you see therapy such as EMDR, IFS, art therapy, etc., being funded for GARS being helpful?
Yeah, I think the more choices we have, the better. I find, like, again, like, so we do EMDR with some of our patients, like it's not the right choice for everybody. So I would say the bigger the menu, the better. Like if we have more choices, it would be better for the patient. And I think group therapies too, like I don't, like a lot of, like, for example, with the Yazidi, like they've been through genocides in the past, etc. They heal by sharing their stories together, through narrative. And so we don't have any way to funded ways to facilitate that with the Yazidi. So I know there was a group, Reach YYC and the CMHA were doing that with the Yazidi in the park last summer or the summer before, I can't remember. And that the women thought was helpful. I mean, they didn't even recognize it as mental health. They're like, oh, I'm going to meet my friends. But they really enjoyed it. And so that was good sort of therapy for them. But again, like none of that is really funded.
Any final questions before I let Annalee wrap up here? Annalee, what should these people take away from today's session and what WrapCap can do?
Well, I would just say that the big biggest lesson that I have learned over the years is that two things. One, mental health is so much more than just seeing a psychologist or a psychiatrist and taking medications. Like it's about everything that all of us do. So all of us have a part to play in supporting people's mental health. So whether that's you're a teacher, a resettlement worker, a mental health provider, family doctor, social worker, etc. Like we all have our part to play in supporting people's mental health. And the other thing that I have learned is that building trust with people and providing people with a sense of, like, again, that sense of agency, like they have power and control over their own lives. It provides people with hope for their future. And so it's like that, again, like all of us play a role in empowering people. So to me, those are the key components. And then the other thing that I've recognized is just the importance of family reunification. Like I have the vast majority of my patients, that's one of the main drivers of their poor mental health. If people come to me, oh, I can't sleep, why can't you sleep? Oh, my child is over in Iraq and they're 21 now, so I can't get them here to be with me. And like they're worried about their safety because they're living in an IDP camp in Iraq. And yeah, that's your normal function as a mother, is to worry about your child who's living by himself and is 21 years old in an IDP camp in Iraq. Like that's a normal response, to worry and not be able to sleep. And I don't really have a pill to fix that. So just the importance of family reunification and making families whole and hearts whole again.
Thank you, Annalee. You're getting a lot of, thank you very much, and studies. You have a lot of resources about depression, looks like this for someone from Colombia. I found those resources really helpful. So if you still have those resources, if you can send them to me and I'll ferry it out, not just to people who attended today, but to all of WrapCap. And to get that long-term aspects of things, that's the point WrapCap is trying to make, and the youth are saying it. Youth are saying it. You can't just say, sit down with me once and I'll be good. But what was happening, I know with the at-risk youth, that for the Syrian youth, it was 4 or 5 years after they settled that they started coming into that at-risk criminality aspects of things. So that long-term thing is very much needed. And Annalee, like COVID, you're running around doing committees. I'm asking you to do things for free and switching up your presentation. Thank you, thank you. And thank you for asking that. The Alberta Building Network has a working table for newcomers with disabilities if anyone wants to join. That is fantastic. Thank you. And I want to make sure I hit everything. Just read a study this morning on long-term effects of mental health issues of family reunification being delayed. Yes, if you have any of those resources, please send them to us here at WrapCap so we can put it all together on our proposed platform for long-term sustainability. And let's see if I can catch up. Wonderful session. Like I said, Annalee, the fact that you actually want to support WrapCap members and go out and help train, crazy.
Yeah, like I go on rants. The other thing I want everybody to know, because we just learned this last week, so the North American Refugee Health Conference will be hosted in Calgary for 2023. And so I think this might be our opportunity too, to sort of leverage that conference to influence IRCC. IRCC is always sort of part of the North American Refugee Health Conference. And so it might be good to sort of highlight some of these gaps and some of the potential solutions during that conference. And so normally, for people who don't know, it's usually been hosted by U of T in Canada, and then it goes to the States and it's hosted by the North American Refugee Health Providers Society. And it goes back and forth year by year, but there was a controversy at U of T. They lost the conference, and now it's solely the group that runs it is that North American Refugee Health Provider Society. And so they chose Calgary to be the first non-Toronto site to host the conference in 2023. So just put that on your calendar. Unfortunately it's going to be in July because there was no hotel availability or at any other time of year or convention availability. So but normally it's held in June every year, and probably moving forward, they said if it's a success, it will every year be or every few years it'll be in Calgary, and it'll probably move between Halifax and Calgary, Halifax, Calgary. So anyway, exciting.
Thank you so much. And that's about the time of the WrapCap conference. We're a youth-led conference, so the project will be doing a conference as well. And like I said, the youth have had a lot to say about mental health processes, particularly international students have had a lot to say about the lack of mental health services that they've provided. And someone's asking if the conference will be virtual as well. I'm not really sure.
Yeah, I know that this year they're doing a hybrid. Like this year it's in Cleveland in June, and it's a hybrid between in-person and virtual. I imagine it'll probably be something similar in 2023, unless for some, yeah, I have a feeling it'll be the same.
Thank you. And I just wanted to acknowledge Siwa said they have lots of good youth programs. Thank you, Siwa. I know you do, and I know your counseling programs. I think the goal of WrapCap is to show this long-term systemic need. And so thank you all for attending not only to the session today, but all the mental health sessions. And if there's other sessions you want to see, because I don't know what you want to see, let us know. The idea is to get information out and training that maybe you don't have access to. Maybe I can find it. But Annalee, Georgina, you're on the call today. The last two sessions, all the sessions have been so, the talk about family reunification is really a hit home. So thank you so much.
Thank you.
That's all, folks. 15 minutes. Drink water, do something else. You're busy. Thank you lots. And if you guys want to see more, you tell me and I'll find it. So in the meantime, please enjoy the rest of your day and take care.
Thanks, Carolee.
You're welcome.
Yeah, that was a great session.
Awesome. I'm glad you guys liked it.
Yeah, I'll be taking that back to